This video is going to go over hormones of the male reproductive tract. So first it starts off with the hypothalamus. So remember from the endocrine system, the hypothalamus is in the brain, has a connection through the pituitary with the infundibulum, and either kind of has interaction with the anterior pituitary or the posterior pituitary. So the hypothalamus is releasing gonadotropin releasing hormone that's going to then go down to the anterior pituitary and cause release of luteinizing hormone or LH and follicle stimulating hormone, which we say FSH. And they're both the same name, whether it's a male and female. So it's going to see based on female, but they do have functions in males as well. So first, the luteinizing hormone, or LH, is going to target hormones. So luteinizing hormone is going to produce more hormone. So it's going to go to interstitial end of the testes. So we looked at those when we looked at histology. And these cells are going to produce and secrete testosterone, which is vital to sperm production, and also other androgens, but we're really focusing on testosterone here. So testosterone is needed for sperm, and we need it at a certain level for proper sperm production. If we're getting to the point where they're off, then we're going to have negative feedback because we want it at a certain range. Again, have testosterone at a specific range, important for sperm production. So testosterone levels, our friend, the negative feedback that we see in kind of the theme and entire part of AMP. So what happens is if we have a lot of GnRH, which is going to release LH, so high levels of GnRH is going to lead to high levels of LH, which is going to lead the interstitial cells to continue to produce testosterone. So you're going to get a high level of testosterone. Well, then we have the negative feedback on GnRH. So it's going to be sensed that there's a higher than normal or higher than needed level of testosterone. So you're going to inhibit the release of GnRH. So you decrease that, which therefore decreases LH, which then is not going to stimulate interstitial cells from releasing testosterone, and testosterone will be used and processed, and levels will again. So it's all the negative feedback that we ultimately go to the hypothalamus at the level of GnRH to lower our LH. Follicle stimulating hormone is going to nurse cells. So nurse cells that we talked about previously are going to be the major promoters of spermatogenesis, making sperm, and spermiogenesis, making sperms move. So growing the tail. So this is going to be promotion of gamete production. So you can think of FSH as gamete production, and in the male system, that's sperm. And you can think of LH as hormone production, the major one being testosterone. Nurse cells also have that androgen binding protein that we talked about. So that's going to take the testosterone that's made by the interstitial cells. So there's nothing with making testosterone. It's just keeping it around at high levels around where spermatids are being made. So we need a specific level of testosterone in the testes, and we need to maintain it. So we bind it that stimulate the maturation of spermatids. So again, this is where we get back to gamete production. So having nurse cells stimulated to secrete this androgen binding protein to keep testosterone levels at the kind of perfect level is going to help stimulate making spermatids and getting to the point where they're growing and maturing normally. Nerve cells can also secrete inhibin, so this is another negative feedback control of spermatogenesis. So if nerve cells are seeing that there is enough sperm or spermatogenesis has been producing enough spermatids, then it's going to secrete inhibin, which inhibin's going to go to the anterior pituitary and inhibit FSH. That's saying, okay, we have enough sperm for now. We can stop, we have some in storage, and we don't need to make more. So it's going to stop FSH at the anterior pituitary, which is going to stop basically stimulation of itself of promoting spermatogenesis. So it's going to inhibit sperm production. Again, this is having to do with sperm production. LH is going to be hormone production. So we can look at kind of all this big picture. So we have the release of the gonadotropin releasing hormone from the hypothalamus. That's going to be kind of a steady release, at least in males, to keep kind of FSH, LH, and testosterone in a relatively kind of normal level, unless we need to change it a lot. So in this, it's going to be kind of consistently released. And we go to the anterior lobe of the pituitary. That is going to release either luteinizing hormone, interstitial cells, or follicle stimulating hormone, which is going to be cystinocytes or nerve cells that are going to have kind of an effect again in the testes. So LH, interstitial cell, so that's going to be testosterone release. FSH is going to be promoting spermatogenesis, the androgen binding protein, or inhibin if it needs to. And again, inhibin is going to be produced if you have enough sperm. So it's going to go back and inhibit FSH. Sometimes it can even have an effect maybe on GnRH, but we're looking at FSH. So we can have a control of spermatogenesis if we have enough sperm. We don't need to make more. So we're going to just have that negative feedback of stop stimulating to make sperm. Testosterone also has an effect not only on the testes, but sex drive, behaviors, bone and muscle growth. So differences between males and females with kind of muscle and bone mass. Secondary sex characteristics of males, so facial hair, fat deposits, things like that. And it also helps with those accessory glands, so the prostate, seminal vesicles, all of that. Then we control the kind of environment, so make it proper so we can have proper spermatogenesis and spermiogenesis with our nurse cells. And then again, androgen binding protein is making sure that testosterone is at the proper levels for maturation of sperm. Lastly, looking at sexual activity. So with males, we have arousal, and arousal is a parasympathetic response. So it's the rest and digest neurons that we have, and they release nitric oxide. Nitric oxide is a vasodilator. That's why oftentimes you'll give nitric oxide if someone's having a heart attack to vasodilate. So if, again, you're vasodilating, so you're increasing the diameter of the blood vessels, then you're going to increase blood flow because more blood can flow through a larger diameter. So you're going to increase blood flow to the penis, and that's what causes the erection, is actually increased blood flow. You also stimulate the bulbourethral gland. Again, it's not only addition for semen, but then again, it's producing mucus for lubrication as well. Emission. So what happens is again peristalsis of the smooth muscles, and this is in the ampulla. So this is going to be where the widening. So again, urinary bladder, the ductus deferens comes superior and then widens. That's really large, but it widens at the posterior side. So we're going to have peristaltic movements through the ductus deferens, but then into the ampulla. It's going to push sperm into the urethra. Seminal glands are going to contract, add their secretions, and so then we're going to have semen entering the urethra. Then at ejaculation, so kind of going arousal, and then you kind of get ready, and then ejaculations is a strong muscular contraction, and it is actually a reflex, and it goes through signals in the lower lumbar and sacral regions of the spine. So that's going to be where signals come from for ejaculation and strong contractions that happen. We also look at erectile dysfunction. So this is either you can't, male cannot achieve or get an erection or maintain one. That can be low blood pressure. If you don't have enough pressure, even when you vasodilate to increase blood flow, then that's not going to allow for an erection. If there's nervous tissue damage, so neural commands that are going to increase blood flow and cause an erection. There can also be emotional factors, so depression, anxiety can actually have an effect on erections. And we have, I'm sure, commercials, Viagra and Cialis are going to be medications that actually inactivate the enzymes that'll stop nitric oxide. So basically, what these guys are doing is increasing the amount of nitric oxide that you have, which again is a vasodilator. So it's going to increase blood flow, and that's what can produce an erection. And both Viagra, especially, was made originally not for this. It was kind of a thing they saw in research that it was actually made for pulmonary hypertension or high blood pressure in the lungs, which makes sense. If you want to decrease blood pressure, you're going to dilate the blood vessels, and that'll decrease blood pressure. But then we still use it. People take it for pulmonary hypertension, but seeing the kind of effects sexually, then it was marketed for that instead.